Good morning, everybody. So, the first part of the hormones, that is anterior pituitary hormones. You know, hormones are the main regulatory system which controls various homeostatic processes in our body. So what are these hormones? So in the hormones, we need to understand the basic secretion of the glands, endocrine secretion and exocrine secretion. Okay. So the one which is endocrine is what? And one which is exocrine is what? Which is hormone? So regulation of the anterior pituitary function. Here we have hormones. The basic definition we need to know. What are these hormones? Can we call this, which is, and here the concept of receptor and concept of hormones we need to understand carefully. So can we call this prostaglandins, histamines which are released? Can we call them as hormones? So the basic definition we need to understand here is hormones are the chemical substances which are synthesized by specific endogenous glands, and they are secreted internally and directly into the bloodstream to act far away from the site of their production and release on the specific target organs. So if this is the definition, first part we will try to understand by specific endogenous glands. Can you tell some glands which secrete the hormones? Pancreas, thyroid gland. Okay. So what is this hypothalamus? Does it release some hormones? Does it release some hormones? Yes? Yes. So here I wanted to stress on that point because they act far away from the site of their production. Is it true for all the things? Majority of the hormones which are secreted, they act far away, but we have some regulating hormones. That's why the hormones which are released from the hypothalamus, we call them as releasing hormones or releasing factors sometimes. Okay. And why this prostaglandins, histamines cannot be hormones? Because they act at the local site, they have their local site of action, okay, and there is no these receptors for this prostaglandins, histamines, they are widely distributed and they have their local action. But here hormones are relatively specific in nature. Okay, their actions are relatively specific and related to specific glands. So tropic hormones, these are the hormones which will be released from the hypothalamus, target other endocrine glands to release their own hormones. For example, hypothalamus acting on this pituitary gland. So what are these hypophysiotropic hormones? These are also called as neurosecretions. Okay, they are released into the hypophyseal portal system through which they act on this pituitary. They reach the pituitary gland and act here. How they act? They are acting by two types of hormones. One is increasing the secretion, that is release hormone, and another is maybe by feedback mechanism. They are acting by release inhibitory hormones. Okay, so this hypothalamus hormones, they travel in the portal system from hypothalamus to anterior pituitary, where they regulate the hormone secretion by anterior pituitary. So hypothalamus, this pituitary gland, we know it is the master gland. Okay, so the master in the sense it can act on majority of the thing, and most of the hormone regulation is by this pituitary gland. But this also has some regulation systems. So regulation systems are long and short loop feedback mechanisms. Is confront. Last 5 minutes. So long loop and short loop feedback mechanisms. This you need to understand what is this long loop and what is this short loop feedback mechanism. I'll be telling it in next slide. Coming to the next thing, that is hypothalamus itself is a regulating thing for this. Okay, so this hypothalamus by release hormone or release inhibitory hormone, they can help that. And other things which are regulating are all pituitary hormones, they can have the feedback inhibitory mechanisms also. Okay, so primarily by the CNS, and this peripheral target glands, they can secrete their own secretion which can go and act on this pituitary gland directly or by hypothalamus and thereby decrease the secretion. For example, this inhibin secreted from this gonads, it can go and act on this GnRH release and thereby inhibit the secretion from the anterior pituitary. So all pituitary gland hormones, they have diurnal variation or they have this pulsatile release of this gland. So here you can see regulation in terms of physical exercise, stress, fasting, what can happen. So once they can stimulate this hypothalamus, okay, there can be release of this GnRH, growth hormone releasing hormone, and this somatostatin, which is a universal inhibitor of hormone secretion. So once they are activating this through portal system to anterior pituitary, then we have this growth hormone release. Growth hormone, initially it has some insulin-like action, later it opposes the insulin action. So we can stimulate the protein anabolic growth on the anabolism and growth on the target tissues, and also oppose the insulin action in carbohydrate and lipid metabolism. So it can go and act on this hypothalamus if the target hormones which are produced from this target glands, if they can go and act on this hypothalamus, we call it as long negative feedback mechanism. But it can come and act only on this pituitary gland directly, then we call it as short negative feedback. Here we are showing the long feedback mechanism only. So anterior pituitary, what it can secrete? Okay, under the influence of somatotropes, it can secrete this growth hormone. Under influence of this lactotropes, it can secrete this prolactin. Under influence of this gonadotropes, FSH is released, that is follicle stimulating hormone, and helps in growth of the ovarian follicles and formation of this sperm. So LH in women can induce ovulation, formation of corpus luteum, and production of this estrogen and progesterone. So LH in men, what it is helping in testosterone secretion. Thyrotrope, TSH stimulates this thyroid hormone release. Corticotropes, ACTH, functions of adrenal cortex, and the steroidal hormones secretion from their hormones, mineralocorticoids, all these things. So this is same thing what we saw in the previous slide, but important thing we need to remember here is this pituitary gland is helping the other glands to secrete their hormones. For example, in the liver, insulin-like growth factor, ECTH on the adrenal cortex, testis, ovary, this LH-FSH is acting on testis and ovary. Thereby they are again producing their actions and produce their work. Thyroid by TSH, it produces T3, T4, but they also have this direct action, that is prolactin directly on the mammary gland, and GH, growth hormone, directly acting on this liver. Okay, so direct action is also there and tropic action is also there. So this hypothalamus pituitary thyroid axis, what can happen? The increasing the level of TSH or this T3, T4 levels, they can go and block this hypothalamus, thereby decrease the secretions. That is there. Okay, so from the GIT there can be inhibin, ghrelin. These are the inhibitory peptides which go and act on this hypothalamus and decrease their secretion. So we have this hypothalamic pituitary adrenal axis which regulates this ACTH secretion, pituitary gonadal axis which secretes this gonadal secretion, and also hypothalamus pituitary thyroid axis, okay, that is helping there in regulation. So coming to growth hormone, the first hormone, growth hormone, what it does. So basically we understand by the term it is promoting the growth. So it should act on the metabolic pathways, protein synthesis, lipid, carbohydrate metabolism, all this, and promote the growth. So basically to promote the growth, the protein synthesis should be increased. Okay, so the more and more muscle mass should be there. Then anabolic effect, okay, it acts as a building block, and it can act on this liver and produce this with the help of this somatostatin, insulin like growth factor 1 and 2. Okay, so initially what it does, initially there is some insulin like effect, that is catabolic action. Later there is action antibodies to that of insulin, that is decreased glucose uptake, because the glucose uptake is decreased means the storage part is increased, the anabolic effect is there. So, and it can increase the release of these free fatty acids, okay, and it can cause this positive feedback to the hypothalamus and release growth hormone, releasing inhibitory hormones where when the secretion is adequate. Okay, when adequate growth hormone is there on all the peripheral sites, there is feedback inhibition by release of this growth hormone, release inhibitory hormone. So increased secretion of growth hormone occurs in sleep. That's why we see babies sleep for more than 12 hours. Okay, because of this increased release which occurs, and they grow in their sleep. And decrease in the levels are seen with levodopa. So growth hormone, if it is decreased in the childhood, what it can lead to? It can lead to dwarfism, okay, and if there is hypersecretion, we can go for gigantism. In adults who it occurs means there can be acromegaly, and this acromegaly is seen in the form of enlargement of small bones, hand and feet, jaw enlargement, okay, cranium, nose, tongue. Most of the organs there is increased activity and enlargement. So in our college, have you seen this babies with decrease in the growth hormone, or the babies diagnosed to have dwarfism? We have many cases of small for gestation. All these things are there. Small short stature for their appropriate age, low weight are there, but exactly the diagnosis of this is made. Have you seen such cases? So recently we were getting this clinical trial based on this thing, growth hormone, where we can give this growth hormone to the babies who are not having this inadequate amount. But the problem here is most of the cases go undiagnosed because of the very costly procedures for the diagnosis of the case. Okay, the diagnosis of the case itself takes more than lakhs to be there, means the doctors themselves will be less interested, and also the patients may not be able to afford it. That is one of the drawback for us. So control of this growth hormone secretion, so we already knew that. So growth hormone, it can be suppressed by our growth hormone release inhibitory hormones. So its gene expressed can be in GI tract and in pancreas. Okay, so somatostatin, we need to know that is a growth hormone release inhibiting hormone from. So somatostatin, where all it is present? So as growth hormone is a universal increase anabolic like thing, thus somatostatin is something like universal inhibitory hormone. It inhibits most of the secretions, maybe insulin, maybe the gastrin secretion, most of the things, histamine release, most of the things it is inhibiting. So its receptors are present in the GI tract. We have it in this pituitary gland. Okay. So another thing we need to remember here is ghrelin, which increases the secretion or decreases via growth hormone release hormone. Okay. So it is helping in feedback inhibition, ghrelin. So this is one of the MCQ question for your entrance. So growth hormone analogs which we are using, that is sermorelin. It is a synthetic analog of this growth hormone. We can use it in suspected cases of childhood short stature where the baby is growing well, or adequate amount of the serum levels are attained, means the baby is deficient, like that. So we can also get this adverse effects because of the synthetic protein molecules. These are injection site pain can be there, hypersensitivity reaction can be there, and urticaria. So we get use of this somatostatin more than this growth hormone, because somatostatin has more uses. What are these? We will be reading it. Somatostatin, it is growth hormone. It can be basically growth hormone release inhibitory hormone. So somatostatin is there. So octreotide, it is a long-acting analog of this somatostatin. So you can see here, we can use this in carcinoid syndrome. Carcinoid syndrome, what is happening? There is increase in the secretion of this gastrin and other local peptides. Okay, so in this syndrome, if we are using, there is decrease in the secretion of this gastrin, and thereby there can be decrease in the carcinoid syndrome symptoms and reduction in the tumor. So vasointestinal peptide secreting tumors, there also it is having inhibitory effect, and in bleeding esophageal viruses we are using. In case of this AIDS associated diarrhea, this is helpful for when it is used for as long as 15 days treatment, subcutaneous injections. It can be helpful in insulinomas because it directly inhibits this insulin release, and sandostatin, we know it is a slow release formulation of this octreotide. Lanreotide, again one more analog of this somatostatin. This is again a growth hormone, release inhibitory hormone. It can be used for this acromegaly and in thyroid tumors. So we have this newer preparations, okay, with recombinant DNA technology. We have prepared this pegvisomant, okay. It is new GHR growth hormone receptor antagonist. It can be used for this acromegaly. What it can do is, it can suppress this IGF levels, that is the anabolic effect on the liver is inhibited. So the important point about it is, it can go and act on this growth hormone receptor and enable coupling, but the further downstream activation of the chain reactions which are needed for this anabolic effect, those are blocked. Okay, so dimerization is there, but blocking the ongoing conformational changes and further phosphorylation reactions which are leading for anabolic effect, that are blocked. So DMRH says, as it is a protein body, it can always induce antibody formation within the body. So somatotropin, that is human pituitary growth hormone, synthetically prepared. Okay, so we need to remember what can cause this growth hormone deficiency. So mainly it is because of maybe tumor which is pressing over this gland, or infection maybe, and also radiations which can block this or cause damage to the secreting organs. So thus somatotropin can be helpful. The negative point about this somatostatin and also a growth hormone. These are the pulsatile release hormones with very short half-life. Okay, so we have this God-made things which are helpful for the person. How means these are very pulsatile nature. That means they are not acting sustainedly. If they are acting sustainedly on something, they can cause some adverse reaction. So this pulsatile action diurnal variation is preventing the adverse effects of this. So and when the adverse effect has already occurred, something like dwarfism and all, we can give this continuous long acting preparations. So T half of this growth somatotropin is about 25 minutes. Subcutaneous it is given. Where this is given, it can be given in AIDS, burn injuries, as anti-aging. The adverse effects what we can expect here is insulin resistance, induction of diabetes mellitus, and arthralgia. So one more growth hormone analog. Okay, so this is mecasermin. So it is recombinant human insulin growth factor 1 and also IGF-BP, that is insulin growth factor binding protein. It is a combination of both of this and formed by recombinant human DNA technology. So they are helpful in again dwarfism and small gestation age. All these cases we can give them, and maintains the desired T half. That is important because in the previous slide we saw the T half was less, and this wouldn't help and frequent dosage which may be cumbersome for the patient. So for that purpose this is better than that. Dose is about 0.04 to 0.08 milligram per kg. Adverse effects it will lead to hypoglycemia. So you already know this thyroid stimulating hormone, no? TSH. So this has become a routine examination in most of the pregnant ladies nowadays. Why? So this initially there was more incidence of this goiter, enlarged thyroid gland, all this. But nowadays, without this goiter also, we are seeing many cases with this deficiency of thyroid hormone. That's why the females are having lot of symptoms of this hypothyroidism. It can start with a roughened skin, constipation, mood swings. All these things can start. There can be hypotension. All these things we need to take it into consideration and go for this TSH, T3, T4 levels. Which will increase first? Yes? No. What happens first? The thyroid gland is not secreting adequately T3, T4. Once T3, T4 is not secreting adequately, what will happen? The TSH levels will increase. TSH is the one which will go and stimulate our hypothalamo pituitary axis to produce more and more TRH. Once more and more TRH, the body thinks if it can release more TRH, there will be more T3, T4. But it doesn't happen like that because of some malformation, and so only TSH levels will increase initially and T3, T4 levels will be low. So this is the picture once we get when we test this T3, T4 and TSH levels. So every 6 months we will be testing after giving this thyroxine, levothyroxine, L-thyroxine preparations. So TSH by per se has very less therapeutic effect, but it can be used for this diagnostic purpose. What it does, it stimulates the thyroid and to synthesize this thyroglobulin and thyroid hormones. Okay, and TSH can be used for this the diagnostic purpose. So thyrotropin alpha, it is now again it is test for diagnosis, detection of metastatic differentiation of this thyroid cancer. Gonadotropins, ACTH, where do they act? They act on this adrenal gland. What if they can release? Glucocorticoids, mineralocorticoids. Yes, do you remember? What are mineralocorticoids? Aldosterone, yes. Which is the main regulator of this aldosterone? Whether this ACTH or the angiotensin 2. It is primarily the angiotensin which is regulating this aldosterone levels, but ACTH also has the action on this. Part of the work is done by our ACTH. Yes. So GnRH, gonadotropin releasing hormone. So this gonadotropin release hormone which act on this by releasing this LH and FSH. LH is luteinizing hormone. It is interstitial cell stimulating hormone in males. Okay. So this FSH, it acts. FSH has action on this. It can release this activin, which can stimulate this FSH synthesis, and inhibin, which can suppress this FSH synthesis. These are like terminal hormones which are secreted from the glands, so which regulates its own secretions. So FSH in females, they help in gametogenesis and follicular development, and LH, it can help in ovulation and formation of this corpus luteum. So FSH in males helps in spermatogenesis and formation of this Sertoli cells. LH and FSH levels, if they are altered, can it go for cancers? Do you have cancers related to this? Testicular tumors, ovarian cancers, fibroids, endometriosis, all these are due to imbalance between the FSH and LH levels which occurs. Okay, so based on this criteria, what we can do, we can use the agonist or an antagonist which can act on this artificially given agonists. What they do, they somehow inhibit the feedback mechanisms which are taking place. Okay, so either feedback mechanism is inhibited or direct stimulation, they are helpful in preventing the cancers. So coming to this gonadotropin release hormone agonist. Okay, so agonists such as this leuprolide, naproxen, gosarelin, most of these drugs find their use in endometriosis. So endometriosis, mainly the estrogen action, where the female is non-pregnant for longer duration of time, there are more chances of going for this endometriosis. So initially what will happen, there is increase in the symptoms of this endometriosis, but later what happens, by way of inhibiting the feedback mechanism, they decrease this symptoms of this endometriosis. So triptorelin is placed in treatment of prostate cancer, and these drugs can also be used for testing and treatment of this infertility. So advanced prostate cancers, uterine fibroids, in vitro fertilization technology, where they increase the secretion of this FSH and LH so that the corpus luteum is formed, where ovulation is taking place normally. In vitro fertilization technology, they are helpful. Coming to this GnRH antagonist, okay, the drugs which can inhibit the secretion of this sertorelix, ganirelix, abarelix and digarelix. So these drugs find their use in the advanced prostate cancer. Don't ask me how the agonist and antagonist both can help in prostate cancer, because agonists, they are somehow inhibiting this feedback mechanism, but antagonists directly they are inhibiting the secretion of this glands, so that there is less proliferation, lesser proliferation, leading to lesser the size of this tumor and less vascularization. So uterine fibroids, endometriosis, all these in vitro fertilization they can be used. So here is one paradoxical conditions where both agonist and antagonist find their use in both the conditions. So natural gonadotropins are obtained from the post-menopausal woman. They are thus monotropin and uropolytropin, and now recombinant FSH. These are also tried. Okay, mainly they are tried for this infertility. Okay, so uses is infertility, cryptorchidism, then in vitro fertilization, Kaposi sarcoma. Where do you find this? It is seen in, it is AIDS related cancer. Okay, remember Kaposi sarcoma is AIDS related cancer, and they also find their use in diagnostic use. Sorry, I was expecting this slide initially. So adenocorticotropin family, ACTH, what they do, they regulate the hormone secretion by the cortex of the adrenal gland. So ACTH, it can stimulate the glucocorticoids, mineralocorticoids, and also androgens. So ACTH can also be released by this tumor and stress, and they can help in this melanocyte synthesis, pigmentation. All these are. What happens to this decrease in this ACTH? What we call that condition? Addison's disease. When it is decreased, and hypersecretion, we have Cushing syndrome. So you can see here the central obesity is there, but you can see the obesity part which is more in the upper part of the chest also. So like obesity, poor wound healing will